So what I want to talk about here is how we as psychologists are also interested in the body as much as we are in the mind. So yes, we talk about thoughts, emotions and behaviour, but we're also really interested in physical sensations and I guess the mind-body duality, as we like to call it. CBT is, or cognitive behavioural therapy, is a commonly used treatment that actually brings together these ideas of thoughts, emotions, behaviours and physical sensations. And they're often applied to many issues and problems, including pain. So this model that you can see right now, it was developed by Christine Podesky in the 1990s to help us understand problems from by understanding thoughts, emotions or feelings, behaviours and physical sensations. And you will see here that the mind components, the thoughts and the feelings, are clearly linked to the behaviours and the physical symptoms. And they're all connected, so the influence on one will have an impact on the other components. And an application of this is thinking about pain. So maybe I might think I might have a flare up. The emotion so that might be a thought, and then the emotion might be, or the feeling might be, I'm scared or I'm anxious about this flare up. The physical sensation might be, I actually start feeling physically more in pain, and the behaviour would be, I want to avoid going out today. In the same way these components are integrated, we propose so should the treatment of pain using psychologists and physical health practitioners. Janine, if we can go to the next slide, please. So let's see how this model can be used looking at the psychotherapeutic ideas. So our thoughts, what we find here is that we enter, we can have quite a few negative cognitive patterns that might be self-critical, or they might be based on some untruths about what actually causes pain. The emotions or the feelings, when we look at them, we notice that perhaps stress and trauma are coming up quite a lot in how people are experiencing pain as an emotion. The behaviours then are leading to feelings that can mean that we avoid doing certain things, because as humans we do have a natural tendency to sort of avoid or run away from threat. All of these points, you could argue, could culminate to, I guess, increase the physical sensation of pain, which in turn contributes to a negative downward spiral. So you can kind of see how that all starts hanging together. If you click again, Janine, bouncing on our screens is what we might, as psychologists, want to say, we want to think of as alternatives to the bits in red. So what do we want to do instead is unpicking those unhelpful patterns, or at least kind of trying to loosen up the model a little bit. So the thoughts, let's look at that a little bit, thinking about how we might talk to ourselves perhaps more gently, with an idea of sort of loving kindness rather than beating ourselves up. And also we want to think about acknowledging the reality in the pain experience, despite there being perhaps no physical wound. Moving on to the emotions, we want to reduce that sense of threat. We do that by thinking about pain in a befriending way. This, of course, is a lot easier if your pain can be acknowledged by others around you, including the professionals working with you. How we use language is also key here, and I'd like to say that when we're working with people who don't speak English as their first language, terms like flare up, scans, even goals might not be met with the neutrality that we hope they might be. And so that sense of threat can be increased simply by the language we use. In terms of behaviours, we like to use ideas from acceptance and commitment therapy, where the underlying approach is to think about the values that we all hold, what helps manage our expectations, about ourselves. What does our life mean now? I guess thinking about purpose and aim. Are what we end up doing, in fact, smart? And are they going to be helpful to us? The physical sensations is all about activating the parasympathetic nervous system from the psychological perspective. This is the calming and the soothing body system. And we know that pain can be reduced with when we activate that parasympathetic nervous system. So with neuropathic pain, when we know that the experience of pain can be shooting, instant, sort of not gradual like other conditions might, where people might experience pain in a gradual way, research says very clearly now that breathing is what our patients find the most helpful in those sharp moments of pain. And mastering the breath is in fact something that can make all the difference. If we can jump to the last slide, which allows me to sum up before I hand over to James. It's just a summary of some of the things that I've talked about just now. So thinking about how we educate, how we think about pain and how we express that to our clients. Are we thinking about the holistic ideas? Are we thinking about that mind-body duality and connect? I think thinking about breath work should never be underestimated. Research says it time and time again, and mindfulness is being shown to be a really effective evidence-based treatment now. We know avoidance doesn't work. However, the concept of befriending the pain does. Acceptance, compassion, the therapies that have evolved around these concepts are massively, massively helpful. They really help bring down that idea of feeling in threat, feeling anxious, and thinking about ourselves slightly differently to how we have done before. Language is core. It's really important, especially when we're thinking about our BAME communities. I think the other thing is, as the Podolsky model suggests, thinking interdisciplinarily when it comes to pain management from the start is absolutely going to help our clients manage their pain in a way that we know, again, has been evidenced time and time again. Some of these concepts have been talked about in the Psychology of Case Management podcast, and I highly recommend you listening into that as a way to kind of get more about some of the ideas I've talked about today.